Good evening, everyone. My name is Catherine Turner. I'm one of the executive managers at the Hunter New England Central Coast Primary Health Network, and I'd like to welcome you to COVID-19 Primary Care Update number 6. So it's very pleasing to know that so many of you are interested and are able to join us this evening to hear an update on where we're up to with COVID-19 in general, but also with some specific focus around aged care, which has been delivered in response to some questions that you've all had. So I'll quickly introduce our panel who are with us. Before I do that, I'll acknowledge that we're meeting on Aboriginal land tonight, wherever we are. So I'd like to acknowledge the traditional custodians of the land, elders past, present and emerging, and thank them for their ongoing stewardship of the country that we live in. And I have to say right now how blessed we are to be living just here. And the other thing I wanted to do before we start is acknowledge that today's International Midwives Day. So as a midwife, it would be remiss of me not to mention that and to give a shout out to the midwives who I'm sure are also working under very strange conditions right now. So tonight we're very fortunate to be joined by a panel of experts from right across from different parts of the region that we're working in. So we'll be hearing variously tonight from, to my right here, Dr. Tony Merritt from the Public Health Unit at Hunter New England Local Health District, Dr. Carolyn Hullick, who is a rare person who's an emergency department physician with a passion for aged care, I think it'd be fair to say, who works with us here at Belmont. Jackie Hewitt, who has a long history in residential aged care and aged care in general, who's working here with us at the Primary Health Network. Also on our panel later we'll have Dr. Charles Robinson, who's a local GP. And joining us from the Central Coast, we'll have Dr. Catherine Todd from the Public Health Unit at the Local Health District, and Mel Pickering, who is also responsible for providing support and looking after residential aged care from the Local Health District perspective down there. So we're really lucky to have so many people, and I have to say the PHN's been working really hard to do what we can with our LHD colleagues to provide some assistance for our residential aged care partners. And we absolutely acknowledge what a challenging time this must be for all of you who are working in this space at the moment. And we are blessed to be able to learn from the history, the lessons from other parts of the world, but hopefully that will be something that assists us as we continue to prepare for a potential outbreak here. So having said all that, I might hand straight over to you, Dr. Merritt.
Tony, to everyone, thank you very much. Thanks for the introduction, and lovely to be back, and I'll just check that the sound is fine. Terrific. Look, lovely to be here and to join you all. Thanks for those who've connected in. And tonight's focus is going to be on aged care in particular, but I'll give just a little rundown on EPI and a couple of changes I thought were relevant. And as always, we will go to your questions. So Slido's open now, the event code PHN6. So please jump on, and as always, if there's a question there that matches something that's close to yours, vote that one up, and we'll rely on the upvotes to prioritise which questions we come to a little bit later in the afternoon. Shout out to colleagues at Vidral and CSIRO. Hopefully you saw the ABC story with that amazing visual that's part of the background there. But pictures of real coronavirus out of the labs in Melbourne. There'll be a couple today, but I think they are just absolutely spectacular. So electron micrography and then some coloration added. All right, these are getting a bit small, but just very briefly, obviously come a long way since we started. I can't really see that screen either. I hope you can. Over 3.5 million cases and over 250,000 deaths. And now I think there's 10 countries with more cases than China, so it's been an extraordinary path. But we're particularly interested in what's happening here in Australia, of course. Just picked out a couple of countries to put on this plot. You've seen something a bit like this before, but this is a linear scale, so not a logarithmic scale as we've seen in the past. This is total cases. Australia there in the orange and a superbly flat to flattish curve. We're in very rare company. I've said that before. It's getting even rarer. So that's New Zealand on the scale just below us, fewer cases, and also spectacularly as flat. And there's really not many other countries in the same company. So Singapore there, you can see climbing skyward after initial control, real challenges with some of the dormitory folk. And I put Sweden on there because Sweden keeps sneaking into the headlines with their strategy with slightly less stringent social controls, and they are anything but flat at the moment. So we're in rare company and have done extraordinarily well. I won't dwell too much on the epi. There's the Hunter New England epi curve with cases, and that is looking just superbly unexciting for the last couple of weeks. So we had one case there over a week ago, and it's over 2 weeks since the last locally acquired case where we didn't have an explained source. So that's exactly what we're looking for, of course. So that is very encouraging. In terms of the age and gender breakdown, that's the 0 to 5-year-olds on the top, hardly any of those, of course. Modest numbers of the under 20s, and then a big peak for the 20 to 30s, and again a bulge between the 50 and 70s, and not so much in the older age group, just consistent with our age pyramid. Slightly more females in the blue on your right than males. No more epi other than that the focus very appropriately is turning to testing, and we need your help very much with this. So this is Hunter New England data. The blue columns match the axis on the left there, that's daily counts of tests, and the red is the cumulative, so up north of 30,000 tests in Hunter New England in total so far. But it's really that daily test number which is an enormous focus for the health service, and that's where we need your help. Something around 1,000 tests a day in recent days, and that's definitely, we're targeting that and above, while we look really extensively to make sure we're not missing asymptomatic or mildly symptomatic cases in parts of Hunter New England and elsewhere. So lots of focus on testing. What are the testing criteria? We've hit you with these every time, of course, but it couldn't be simpler now. So there's the testing criteria. Anybody with respiratory symptoms or unexplained fever. So the capacity to test is superb at the moment. We really want to look out people who we wouldn't have been able to target with testing if we'd gone back a month, certainly 2 months. But anybody with respiratory symptoms or unexplained fever now, it's appropriate to target with testing. So again, thanks for your help with that. That comes straight out of the New South Wales Health Guidance. If you're looking for updates, their website's superb for all of that. They do flag on the website adjacent to that the kind of high-risk groups where it's particularly important to test, so institutional settings, Aboriginal and Torres Strait Islander people, and people, of course, who've travelled or in close contact with known cases of COVID-19. So testing criteria getting much simpler. And access to testing, we may well hear more from the PHN later in terms of PHN supported testing across the health district here in Hunter, New England, that you can see a rapidly expanding list of testing sites and a lot of focus. You'll see at the bottom there, our first, is it a mega testing clinic? Mass mega. We have exactly the right person here. Carolyn can tell us more about that. But at the Newcastle McDonald Jones Stadium opening Thursday, then there'll be, from Friday. So you can book in from Thursday on a phone number. It's an appointment system like the drive-through at Belmont and other facilities. and then there'll be capacity to test very high numbers of people through there, and that's open certainly for the next 2 weeks or so. So great opportunity to direct people there for testing, or people can self-direct, but they do need to ring ahead and make an appointment so that we have orderly queues of people. So lots of testing capacity, lots of testing places, and it's a really, really important focus. All right, just a couple of things to say about community-based management of COVID cases. We've heard a lot before in previous sessions about COVID care in the home, and the details of that are in the excellent health pathway. No more on that from me just at the moment. But I will flag that we at Hunter New England, the Public Health Unit, we recognise we haven't been as good as we should at referring on details of your patients when they have confirmed COVID. They're mild enough to be managed very safely at home in the community with your care. The health pathway's there to support that. And so this is our next step at improving our communication with you, is to send a discharge, if you like, or referral when somebody's in that situation. We'll do that through access to the secure electronic messaging service. We haven't used that at the Public Health Unit before, and that'll arrive in practice software through the magic of medical objects. So look forward to your feedback on that. I hope that is a really appropriate and useful innovation. Now, there has been a little change in the release from isolation I wanted to flag too. We've covered the basic components of this at the previous sessions. So people who get to 10 days after onset of their symptoms and 3 days after resolution of all their new acute symptoms, they are eligible for release from isolation at home. But we've known for a long time there's a group of particularly healthcare workers who need additional testing before they're cleared to go back to their workplace. You're familiar with that, and the Public Health Unit is retaining a key role in coordinating that release from isolation and return to work for healthcare workers. The news that's changed really substantially with the latest version, or the second latest version of the CDNA song, is that the group of high-risk settings has been substantially expanded, and now people who've had confirmed COVID-19 disease who are returning to any of these settings, and I'm sorry there's a lot, it's probably quite small font, but this entire group now needs to have 2 clearance swabs before they can return to these settings. They can be released from home isolation into the community, but in terms of going back to work or back into these settings, there's now a requirement that all of this group have 2 negative PCRs. It's a bunch more work. It's going to create challenges. I'm not sure this list will stay exactly like this over the next weeks and months. This really is an enormous challenge. But just flagging that's the case at the moment. The top 2 we knew about already, healthcare settings and aged care, but now it includes going back into institutional settings such as military groups, boarding schools, educational settings, so that's schools, childcare centres, correctional centres, detention centres, Aboriginal and Torres Strait Islander rural and remote communities and outbreak settings. So just flag that there's, for some of your patients who've had confirmed COVID, the release from home isolation, unchanged, but return to work now will require extra testing, and some of the challenges that go along with that, and there certainly have been some challenges, particularly in this group who've confirmed infection and then swabbing for looking for absence of virus, using such a sensitive molecular test as we have with the PCR. Lots of challenges with indeterminate or persistently positive tests. And for the vast bulk of these people, and this can continue for weeks and weeks after recovery, and this is almost certainly a non-viable virus for the vast bulk of these. So it's a challenging pathway for us to navigate through. Does flag a plea, I know you've heard it from us before, but please don't order tests on recovered people unless it's going to be really material to their return to work. So ordering tests in the context of someone who's cleared from home isolation and is fine to join the community, not going to a high-risk community, a test in that setting adds nothing and potentially creates real challenges if it comes back with one of these surprises. So strong plea from us not to test in those groups. Thank you very much, Carol, and is cheering on the same team. We've talked about, or you've asked about gowns on and off for many of these sessions now, and this was included in the updates to the PHN pathway, so I suspect you've seen this already, but just to emphasise that finally we did get that advice we knew was coming from the Australian Health Protection Principle Committee, that for specimen collection, the sort of setting where you might well be faced with in your practices, so specimen collection from somebody who's only got mild symptoms, then a gown is not strictly required. Again, a gown, as you've heard from John Ferguson and others in the past, it's really there if there's going to be fluid contamination of the clothing that you're wearing. So critical to wear the face mask and eye protection. They're your key elements. Obviously a gloves at those times, but for those milder patients, a gown. There's your formal national level written evidence that is not something that's required. So they were the key updates for me. There's another extraordinary picture from our Vigil and Cyro friends. Just a couple of slides, if I may, on aged care. Literally just three. Catherine Todd, when she joins us in a moment, I can see her in the background there, has more on aged care epi from our colleagues in America and the UK. So just a couple of slides from me. First, of course, this is a highly vulnerable population. What do we know in terms of Australian data now for mortality across the age groups? And again, this figure will be a little small, I apologise, I'll just talk you through it. This is the most recent update that's been published in Communicable Diseases Intelligence, so public domain, of course. And at this stage, there were 77 deaths in Australia. The median age of those who died was 79, and 75% of those deaths were between 74 and 84 years of age. So this is overwhelmingly the deaths accrue to those in the older age groups. And those box and tail charts there to the right kind of capture that. Again, it's a small image, I apologise, but the chart on your left is the distribution of ages of all cases, and so you can see the median middle age somewhere in the 40s, and then the graphic on the far right is the distribution of age of all of the deaths, and as you say, well and truly loaded to the top of that age spectrum. The one in the middle is hospital admissions. All right, what do we know in Australia? Well, look, there's not been a lot in the public domain published yet in terms of total cases and experience in aged care. Clearly, this is something that's of enormous interest. Lots of media will touch on a couple of those things, of course, in a moment. Again, coming from the latest CDI update, the time they published, there'd been 103 cases of COVID associated with residential aged care. There was 24 facilities, so there's some reassurance there, 103 across 24. Clearly there's been some big outbreaks, but there's also been a significant number of facilities with just a few cases. That's good news to hang on to. Amongst the 103 cases, 60 of those in residents and 40 in staff. So really key issue here, clearly for staff, but the deaths have accrued overwhelmingly to the residents, of course. And in New South Wales, not a lot published yet. We look forward to more detailed reviews here, but again, it's been a mixed picture with some examples of infection in residential aged care residents or carers and health staff being confined to small numbers, but a couple of spectacularly large outbreaks which underline exactly why we're talking about this tonight. Of course, we've all heard of Dorothy Henderson in the North Sydney. That outbreak's well and truly under control now. And in the RAP there were 17 residents, so the attack rate across the facility was 24%. So that is highly problematic, but it is nothing compared to some of the experience that Catherine will tell you about a little bit later. There were 6 deaths in Dorothy Henderson. And Newmarch House we see in the news every night, of course, at the moment. So these are the latest figures I could see with 37 residents, so around about a 37% attack rate, 15 deaths and 28 staff infected, very much an ongoing concern. And I can see already there's some questions about Newmarch House on Slido. We may or may not be able to help too much with that. We're not inside the response to Newmarch, but we can certainly talk to some of the principles and how that might apply to outbreaks when they occur in Central Coast and Hunter, New England. All right, and so that is the end of my talk. Again, another shout out to Cyro and Vidral. Indeed. How am I passing to you?
No, is it going to?
Oh, it's a Catherine. Sorry. Well, just say, Catherine, I have your slide here too if you need it, but we're just waiting to connect to the audio. Do you want to try again? Yeah, Catherine, we're not hearing audio from you at the moment, so if it's possible for you to double check the muting on your end, that would be great.
Okay. Okay.
So Catherine, we'll just pause on the Central Coast contribution for a moment while we work on the audio.
And then on to it.
And I think it makes sense then in that case to cross to you, Carol.
Thank you.
Yeah. If you've got a different
No, I think you'll put my presentation up, is that right? I need to open it? Okay. Hang on. No, it's that one. No, it's all right. The other one. It's that one. Yeah, just go to start. Thank you. So hi everyone, my name is Carolyn Hullick. I'm an emergency physician, and as Tony and Catherine have mentioned, I've also got an interest in older persons care. And so I'm just going to go through a few things about ED and what we're doing in Newcastle locally to put it into the context, I think, of the COVID response. So the ED is often criticised for its approach to care of older people. But there is a group of us across Australia who are very passionate about this topic, and one of them is my friend Namat, who works on the Gold Coast. And this is one of the slides she always puts up, and I think it's a beautiful slide that says, "To care for those who once cared for us is one of our highest honours," and I would continue to agree with Namat. This paper was written in 1947. So that's part of the reason why I like to put it up, because we're actually really slow learners as doctors and nurses. But it's actually worth reading the text if you've got time. But basically, Dr. Asher in 1947 really clearly described the risks of hospitalisation. And when I was a junior doctor, we were always trained in the emergency department that patients are not safe for discharge, but I would argue the frailer and older you are, that they're actually not safe for admission. And all those diagnoses are listed there, go through all the risks of hospitalisation. So some of the data comes from a systematic review, and some of it's our local data in this table. But basically you can see that if you live in the community and you're older, over 75, then you've got much higher risk than the general population for pressure injuries, delirium, invasive procedures, hospital-acquired pneumonia. But if you're in an aged care facility, those numbers go up dramatically. So pressure injuries, 4.3%, can go up to 20% in some systematic reviews. So just be mindful of that when we're sending patients from aged care facilities to hospital. But our ACE data, which actually includes 12,000 aged care facility presentations across Hunter, New England, is the data that's below. So if you come to an emergency department and you're admitted to hospital and you're from an aged care facility,
7% of those residents will die in hospital during that admission. The thing that I think I would actually like to work more on with the aged care facilities and general practice is around the fact that 33%, so a third of those patients who die during that admission actually die within the first 24 hours. So I would actually argue that some of those transfers are actually futile or preventable in that the person was ultimately dying anyway, and that maybe transferring them to hospital wasn't necessarily the right thing to do. Obviously, if they had significant symptoms and distress, we want them in hospital if we can manage that better, but I think some of them probably didn't need to come. If you've come to an emergency department and you're from an aged care facility in Hunter, New England, 26% of those patients will have died within 3 months of visiting the ED, and 41% will have died within 12 months of visiting the ED. So as you can see, the residents increasingly in aged care facilities are extremely frail, and I think with our fabulous community packages that patients have at home now, where they can get visits 2 and 3 times a day, 7 days a week, means that the population in aged care facilities are increasingly frail. So we run the aged care emergency service across Hunter, New England, and Jackie's worked with me on that for a very long time. And it's really a service that's about supporting the aged care facilities and empowering them to actually manage the patients better, rather than necessarily being a flying squad that goes in and manages acutely unwell residents. So 24 hours a day, in partnership with the Primary Health Network, the aged care facility nurses can speak to a nurse in either the emergency department or the PHN. There's a whole bunch of evidence-based algorithms that are available, mostly symptom and problem-based rather than diagnosis, because it's about nursing. Probably the most important thing we do is get them to clarify the reason for the transfer. In one of the focus groups that we did initially, when we were setting up the ACE programs, one of the aged care facility nurses said, "We sent the patient to hospital with a sore hip. They came back with a pacemaker, but they still can't walk." So I think, it's actually difficult in the ED for us to know what's required of a resident if they've come on their own and they've got significant cognitive impairment. So for me, sorting out the reason for the transfer is probably the most important part of the whole process. We manage them proactively in the ED with the asset nurses, and as I said, a lot of the education is actually around empowering the aged care facility staff to feel that they can manage the patients themselves. And the other thing I think that's been really good about it is that we've got this amazing community of practice that involves the PHN, GPs, ambulance, local hospitals, EDs, aged care facilities, where we all talk about the program and where we're up to. And each quarter we've been talking about different things. With the COVID outbreak, we've actually now got weekly, we've had daily webinars this week, and we're moving to weekly. We've had really good feedback on the webinars, and just giving people the opportunity to kind of feel that we're all there together, and this is actually a really difficult group of patients, and that we're all in it together, because I think everyone's really concerned about if there's an outbreak, are people going to be left on their own and they're not going to get the support that they need. So we've been really happy with the response. And this kind of describes it, but it's around building capacity of staff in the aged care facilities, improving communication and collaboration with the aim to reduce avoidable, maybe unnecessary is not quite the right word, but presentations to ED that could have been managed differently in the aged care facility. And I think, again, in the COVID environment, some of the things we'll talk about goes on the consequence for a patient after they've been to the ED and needing to be isolated for 14 days has a significant impact on their well-being. These are some of the resources, and that's the ACE support line that all of you are welcome to call. And there's also the website with the username and password. And it's a link to Health Pathways. So there's a lot of the stuff between links between Health Pathways and ACE, but I suppose the audience for ACE is more in line with nursing rather than the GPs, which is Health Pathways. This is an example of some of the algorithms and pathways that are within ACE, and it's around goals of care. And as I said, from my perspective, this is the most important part of care in aged care facilities. It's actually, just because someone is acutely unwell doesn't mean that they necessarily will benefit from coming to hospital. So we go through what's the purpose of the transfer? Like I said, in the person that had the sore hip, the purpose of the transfer was actually that they needed an X-ray, not that they needed an ECG and a pacemaker and a whole lot of other maybe medical input that they didn't necessarily need. And then the other concept to think about is the continuum of health, where we move from curative care when we're fit and healthy, to restorative care when we have chronic disease, to palliative care when we're thinking about symptom management, to terminal care, which is in the last days of life. And I think if you think through that continuum, it helps to understand goals of care. One of the things we've been talking about a lot in the ED, which I think would be useful in general practice, is the clinical frailty scale. So the clinical frailty scale comes from Canada and is used heavily in the NHS. And I think for me it helps with some of the end-of-life conversations that I have in the ED because it actually gives a person an objective measure around their frailty. So frailty, I think, is a condition where it's the person's ability to return to their baseline after an insult or injury. So if they have an infection, how likely are they to get back to how they were 2 weeks ago? So that's clinical frailty scale. It actually takes only a few minutes, and that link is actually a really useful one. This next slide, though, is part of that link, and it actually talks about outcomes. So as you can see, if you have a frailty scale of 9 is terminal, expected to die in the next, I can't remember, a few months, I think. But as you can see, if someone with a very high clinical frailty score comes into hospital, they're the 30% chance of dying in that admission, and therefore the conversations that we should be having are actually very different to the conversations if they're a fit and healthy 100-year-old in the UK who's just raised £50 million would obviously not fit into the clinical frailty scale grade of 9. So anyway, it's worth having a look at, and if any of you have got questions, I'm happy to answer them. And that's the link to the training module. It takes about 10 minutes and it's worth doing. Just going to mention telehealth. One of the great things that's happened out of COVID, because there is actually quite a lot of good things that have happened, is telehealth. And now in the emergency department, a lot of the nurses, when we're talking to them from the aged care facility, we're actually able to say, have you spoken to the GP? And they are actually able to talk to the GP and get a telehealth consultation, which is making a massive difference. And I hope that that's one of the things that continues out of after COVID. This is our health pathway, and I'm just going to try and log into the health pathway that's actually live now so that I can talk through some of the sections, I hope. Oh, it's on the screen now. Okay. I just can't see it. Yeah. Is that all right? Thank you. Thank you. Give me 2 secs. Where's my assistant when I need her? No, not doing anything. I think it might have died. That's all right. I'll look at this one. Yeah, you can fix it and I'll look at this one. So, sorry guys, I'm just moving, which I shouldn't be doing, I know. Failed. I'm just going to look at the computer here. So as you can see at the top, oh, you've got it on already. Geez, I clearly failed, didn't I? The top section is the background, which is actually very similar to the community health pathway that talks about what the COVID virus is and where it's come from. It talks about incubation periods, and it also lists some of the references I think that Catherine will talk about shortly in regard to expected outcomes from aged care facility outbreaks. The next section is on assessment, and we talked about preparatory stuff that would be really good for GPs to think about in relation to COVID. So let me just open that, hang on. So telehealth we've talked about. I think there was some issues raised by some of the GPs around the ability for aged care facility staff to actually take observations There's lots of training that's available in relation to that. We haven't found that to be a major issue locally. Having access to PPE, oxygen, antibiotics that Jack is going to go through later, and then some of those links, things like the cDNA guidelines that Tony's been talking about. One of the things we've asked is that GPs or the aged care facilities think about doing some baseline observations more regularly with residents at the moment, so that if there is an outbreak, we'll have a better understanding of what their things like baseline saturations are. And then the other thing is around residents returning from hospital. So our recommendation locally for Hunter, New England, is that if a resident is returning from hospital, that they should be, if they're not COVID positive, that they should be observed for 2 weeks, and that they should have standard precautions and be in self-isolation. So they can still have visitors, but they need to be in their own room, and if visitors are coming, they need to be washing their hands, are the main issues related to that. And then observations twice a day, again, with really vigilant surveillance to ensure that if they do develop any symptoms, that they're swabbed. Nebulisation's a big deal for COVID spread, so ideally nebulisers are changed from nebulizers to spacers. There are some residents in aged care facilities that are on BiPAP and CPAP, so we're asking that GPs go back to the respiratory physicians or consider it themselves as to whether they should continue, particularly if there's actually an outbreak, because CPAP and BiPAP is going to be one of the major risks to the staff in the aged care facilities. I think the other thing we talked about is the current health status. So reviewing the residents' chronic disease plans and just thinking about have they optimised their chronic disease plans in relation to heart failure, diabetes, dementia, just to be sure that things as current as they could be, and also that they've had their influenza and pneumococcal vaccinations, because obviously if they get influenza and COVID outbreak in an aged care facility, that's going to be pretty devastating. I think reviewing advanced care plans, we had a patient in Belmont ED last week who was 97, and she'd had a advanced care plan that was written in 2013 and hadn't been updated since. And I just think it'd be helpful again if we could review the plans sooner rather than later, just so that we know in an outbreak what the expectations of the patient and their family are. I think signs and symptoms. I think the issue for older people and COVID is that we can expect a whole lot more atypical symptoms, and Catherine might cover some of this, but in some of the reports from North America, the patients were classified as asymptomatic and then pre-symptomatic, but I think if you realise that most of the residents in aged care facilities have cognitive impairment, I suspect it's actually quite difficult for them to be able to report minor symptoms. But confusion and delirium are obviously one of the things that we really want to be vigilant about and think about whether it could be COVID. Risk factors. So as I've talked about frailty, obviously aged care facility residents have got most of the risk factors to do not well in a COVID outbreak. Examination, I think, observations, one of the things that they've been talking about is patients having oxygen saturations a lot lower than they appear to have clinically, and an unexpected hypoxia. Testing, I think there's some work to be done on training the aged care facility staff in order to take nasopharyngeal swabs in aged care facilities, and maybe Jackie might touch on that. And then I think making sure that the public health unit is notified if there's any concerns or any outbreak in an aged care facility. Often public health will probably know before the aged care facility, but may not always occur. And then in the outbreak, I think we're going to go through some of this stuff later, but there's a lot of issues I think around that we'll talk about related to infection control when there is an outbreak. And then the last part of the pathway is around transfer to hospital. So as I said before, the management of COVID is supportive care, which is supporting the patient to recover or supporting the patient symptomatically until they recover. So from my perspective, there's a whole lot of criteria around hospital transfer, but really it's the patients who have symptoms that are so distressing that can't be managed in the aged care facility, whether that's palliative or during an acute illness. They're the ones who really need to be transferred to hospital. And if they stay in the aged care facility, as I said, there's all the issues that we'll talk about in relation to an outbreak and how that gets managed. But for them, it's monitoring their hydration, their oxygenation, the medications to support them that may need to be stopped for if they are dehydrated, again, often in the ED. I think we see residents from aged care facilities who have been probably sick for a few days and they've continued with their antihypertensive medications, for example, and they come in hypotensive, and we wonder about whether it's sepsis, but in some ways it's actually just related to the fact that they've been diligently given their medications. Supplemental oxygen, I think one of the things Jackie's going to touch on is accessing oxygen and thinking, aged care facilities thinking about what they can do to plan for an outbreak. Delirium we've touched on, and then I think antibiotics if you think it's a secondary infection. And basically the guidance in the pathway is related to the therapeutic guidelines, and there's community-acquired pneumonia guidelines there. Investigations, I think, are the kind of investigations that you would do for a patient where you're concerned that they've got pneumonia. And another one to think about is that some of the patients also can have cardiomyopathy and ischemic problems, so whether you might consider whether you do a troponin. Chest X-ray, I suspect, is going to be difficult to be arranged in an outbreak, but we do have a list of aged care imaging providers who are happy to do imaging for patients in the community. I think that's about it, really. I might just go back to my... Anything else, Sandra, you want me to cover? Oh, the palliative, okay, sorry. So we're working on a palliative, I think Sandra and the PHN team are working on a specific palliative pathway for COVID, but there are some information here on a death certificate in an outbreak with a resident who is COVID positive. So we're seeking advice, but at this stage it looks like that GPs can write a death certificate via telehealth, but we're not sure that they're going to be able to write a cremation certificate via telehealth. So we're kind of working through that. And there's some information on handling of deceased bodies in COVID and funeral directors information, which is all a bit morbid, really. And I should have done palliative care before I went straight to death, but there's some advice from palliative care who are always happy to provide specialist advice to residents in aged care facilities. And then if you click on the cares in the last day of life, there's a whole lot of information on symptom management, and I find the medication page particularly helpful in terms of thinking about what kind of anticipatory prescribing that's required for a resident from a GP perspective. And I think I'm just about, oh my goodness, that's not my computer, that's why. Need the donk. So as I said, the ACE program is a massive deal, and it requires a lot of, and writing a health pathway is a massive deal and requires a lot of support from a lot of people. But I particularly want to thank Jennifer Briggs, who's one of our GPs who works in a lot of aged care facilities in Newcastle, John Ward, who's a geriatrician, Charles, who's going to talk shortly, and of course Lee Fong, who's very helpful for all things related to aged care and health pathways. So thank you. And I think we're going to cut to Catherine now, I hope, in the Central Coast. So back to the epidemiology about what I just talked about.
So hopefully you can hear me this time.
Please go ahead.
Great. Let me just go to full screen. Sorry, there we go. So yes, just to follow on from Tony, I'm just going to give a brief update on what's happening on the Central Coast, and then I've just done a quick look at some of the international experiences around residential aged care facilities and COVID, and what lessons we can learn from their experiences, because there are a lot of experiences and definitely a lot of lessons. So just to recap where we're up to with COVID on the coast. So far we've had 116 cases to date, and those who are paying attention may notice that this number is actually lower than when I last presented, and that's because we define cases by people who are residents on the Central Coast, and we had a couple of people who were on the coast and were diagnosed and treated on the coast, and now that they've recovered have been able to return to their homes elsewhere in New South Wales or interstate. So that's why our numbers appear to have gone down. Of those 116 cases, 76% have been locally acquired. About 20% or 23 have been contacts of confirmed cases or in a cluster. And we've had 5 locally acquired cases where we weren't able to identify the source of their infection. But the excellent news is that 115, so all but one of our cases, are now recovered and released from isolation. And the one that remains is clinically well and just waiting clearance for them to be able to return to a high-risk setting. So this graph just shows our testing of residents from end of January to date. And what I just wanted to show here, the really encouraging thing was that the call for increased testing has been heard, and we've been able to achieve pretty good rates of testing on the coast. In the last week, I've managed to sort of see the highest rates we've seen. We've also, this might get talked about a little bit later, but we just also had, along with our fever clinics and our private labs that have been doing pathology, we've just had open at Erina an additional testing clinic run by the PHN. So we're really hopeful that that will mean that everyone on the coast that needs a test is able to access one. And this is just a graph showing our confirmed cases by onset date. So we're very similar to Tony. It's nice and boring for the last few weeks. So our last case had their onset on the 7th of April. So almost a month ago now, and that time we haven't had any new cases. So that's really encouraging, particularly in light of all the increased testing we're seeing, that at the moment we certainly seem to have got on top of it on the coast for the moment. So now I'm just going to move on to talk about COVID-19 in aged care facilities internationally. A lot of this was based on a pretty rapid review of mainly some media, because there's not a lot in the public domain or in publications about what the experience has been. So hopefully most of the reporting seemed pretty good and not too sensationalized, and hopefully I've gotten the grains out of it, that are the things we can really use. But of note, and most significantly and perhaps concerningly, is that the World Health Organization is reporting that their belief that up to half of COVID-19 related deaths in Europe currently are occurring in long-term care facilities. And nursing homes have high transmission rates for infectious disease for a range of reasons, you know, crowding, sharing of bathroom facilities, close care being delivered by carers, gathering in common areas like dining rooms, and television rooms, and low preparedness for infection control. And when you couple that with the fact that we have a naive population, that the elderly seem particularly susceptible, and that the burden that this has placed on healthcare services, it just has been an absolute recipe for disaster for aged care facilities. And there's been some really devastating stories coming out of other countries internationally of actually some facilities being completely overwhelmed, and the staff either unwilling or unable to present to work, and them needing to call in government agencies, or in the case of Spain, the military, to support those aged care facilities because the residents had been essentially abandoned. So I wanted to focus on the US experience and also the UK experience. I've got a little bit more on the UK because it was actually quite difficult to get any numbers out of the US. That's similar to us, they have a reasonably decentralized system where all their states essentially each do their own thing. Some states report numbers, some don't, and the CDC didn't have any collective information. So I've just pulled up some key things that were interesting. So similarly to has been seen in Europe, in the US, the belief in the states that were reporting, more than half of the recorded fatalities had been from nursing homes, and that was particularly in some key states like Pennsylvania and New York, where there's been a lot of cases. USA Today had actually done, so the news agency, the news organization USA Today had done a lot of work around this and had approached all the different states to try and get statistics and actually made their own website. And they were reporting that over 97,000 residents and staff have tested positive to date. In the state of New Jersey, immediately next to the state of New York, they were putting that 86% of the state's 575 long-term care facilities have had COVID outbreaks. So almost all. The US, actually, their very first COVID deaths were in aged care facilities. So there early in the year appeared to be local transmission occurring in Washington state, which was ultimately sort of came to light when there was this outbreak in an aged care facility, which ultimately led to over 30 deaths. And at the time, a CDC team went in to help try and manage this case. And they did quite extensive testing of the residents. And based on that experience, they reported that residents with COVID-19 may not report typical symptoms. So they may not report fever, they may not report respiratory symptoms, they may appear to be asymptomatic. Although, as we just heard, in a cognitively impaired older person, they may not be able to tell you about their sore throat or their headache. And they felt that unrecognised asymptomatic and pre-symptomatic infections likely contributed to transmission. And in that outbreak, they went out and swabbed everyone and identified 13 positive people that appeared to be asymptomatic. And then when they went back a week later and we re-swabbed everyone, 10 of those 13 had become symptomatic. So at the time they were swabbed initially, they were likely pre-symptomatic. So based on their experiences to date, the CDC has suggested the following priorities for nursing homes, which are to keep unrecognised COVID-19 from entering the facility, identify infections early and take actions to prevent spread, assess current supply of personal protective equipment and initiate measures to optimise supply, and to quickly recognise and manage severe illness. And the CDC actually has some really great resources on their website that I hadn't been aware of until I had a look today to support aged care facilities, including checklists, lists of essential PPE and when to use it and that sort of thing. So the UK experience has also been quite interesting, and they're slightly different in that they're much more centralised, and so there's much better data. So as of the 1st of May, of 15,500 care homes in England, 4,500 had confirmed or suspected outbreaks of COVID. So that's nearly 30% of all their care homes in the UK. And in the week ending the 26th of April, they reported 1,000 new respiratory outbreaks, and 970 of these were from care homes. And just to give that a little bit of context, so this is regular reporting that they do as part of their flu tracking. And we do something very similar in New South Wales where, an outbreak of a respiratory illness in an aged care facility needs to be reported to public health, who then track the numbers. And in the last two flu seasons, so 18-19 and 17-18, in any given week, they never have exceeded 250 outbreaks reported that week. And now they're reporting 1,000 outbreaks last week. So they're really significantly above what they have ever experienced previously. And almost half of those outbreaks have positive tests for COVID-19. The other half are highly likely to be COVID-19. And so in terms of what that means for mortality, so this graph on the right is from the BBC. And this shows the weekly death registrations from care homes in all of Britain, reported to their National Statistics Office. So the dotted line is the average numbers of deaths that they would receive every week. And as you can see, prior to April, they were never having more than 3,000, and it's gradually been increasing until the week ending 17th of April, they had 8,000. And I guess to put a bit more of a number on that, prior to April 10th, in care homes, they'd attributed 1,000 deaths to COVID. In the 2 weeks after that, there were then 4,000 deaths, so deaths increased by 400% in a fortnight. And of these 4,000 new deaths that were reported, half were reported in the last 5 days of the reporting period. So essentially the number of deaths in care homes is increasing exponentially in the UK. Scotland has slightly better data and they've been collecting it for slightly longer, and they reported that 40% of their deaths in care homes up to the 26th of April were in care homes, 40% of all their deaths from COVID were in care homes. So the UK experience it teaches us a lot, because there's a lot of reasons why COVID has taken off in their care homes outside the fact that they already had an ongoing large outbreak of COVID. Initially, there were difficulties with data collection and accuracy and reporting delays, which has meant that perhaps this problem hasn't been recognised as early as it could have been. So initially, they weren't reporting deaths that were occurring outside hospital settings, which meant that the picture of who was dying of COVID in care homes was skewed, and they're now reporting that, which does give us a better picture. In aged care facilities, they were suffering shortages of PPE, very similar to we experienced here in Australia, in that everywhere was trying to get PPE all at once, and there were significant shortages of them being able to access it. There was also difficulty accessing tests for residents of care homes. So I wasn't able to get a 100% clear understanding of how this worked, but it appeared to be that in order for a resident to be able to be tested for COVID, the aged care facility had to make a special request to Public Health England, who would then send out a representative to actually do the swabbing. And initially they were saying that they would only swab one person, and if they were positive, then they wouldn't swab anyone else because they knew the source of the outbreak, which is what would normally happen in something like influenza. But it did mean that it was very difficult for some facilities to continue swabbing. And also, once things started to take off, the ability of someone to come out and actually swab the residents from Public Health England was severely interrupted. So now they're really trying to address that by establishing these mobile testing units. So they have 8, and they're vans that drive around and can go out to the facility and test. And they've actually called on the military to deploy another 96 of these vans to go out and be able to do testing, not only in aged care facilities, but in other locations that might be sites of ongoing transmission. There was also significant difficulty in workers accessing testing. So again, reading the newspaper articles about this, it appeared to be that if a worker thought that they had COVID-like symptoms, they couldn't organise their own test because access to testing was severely restricted. They had to approach their employer, who would then approach the National Quality and Safety Organisation that regulates aged care facilities, and they would organise the test. So, that's especially if you've only got mild symptoms and you're a worker, that's a big barrier to being able to access a test. In addition, it sounds like there wasn't nearly as many testing facilities as we've had here in Australia. So they were doing all their testing centrally at the Public Health England labs. They didn't have as many labs, and often a worker would have to travel a considerable distance to be able to access that test if it was in fact organised. There are reports of some workers needing to travel 30 miles to the closest testing facility. And a lot of these workers are not very well paid. They're often in areas where they might not have a car and therefore have to take public transport as well to access a test. And so logistically, it just became too difficult for them to be able to seek out that test. There was also movement of workers between facilities, which is an issue we have here and usually often in influenza season. So but that again, once COVID was established in a facility, you might have symptomatic or mildly symptomatic staff that aren't able to get a test that feel well enough to work and then go and work in another facility and then introduce it into a new facility. And finally, again, there were reports of discharging of positive patients from hospitals to aged care facilities. So because, they were expecting this tsunami of cases to come in and severely impact the NHS and their ability to care for patients, they were really pushing to get as many people out of hospital as possible. And there were some reports, again, this was from a news article and not from a peer-reviewed journal, that aged care facilities were encouraged to take back recovering patients, even if they were positive, because they could then nurse them in the aged care facility with barrier nursing. But then when you couple that with the inability of the aged care facilities to access sufficient PPE and possibly a not as good understanding of infection control, it may have meant that a single patient discharged from a hospital that was positive then led to an outbreak in that facility. So a lot of these have been being addressed, but they do still sound like they have a few challenges to try and get on top of this. A key one is struggles with staffing. So the social care sector in the UK, much like probably everywhere, sounds like it's underfunded and perhaps understaffed. So they reported that even prior to COVID, there was a large number of vacancies of assistants in nursing and the other workers that would typically work in an aged care facility. So they already were short of staff. And then also there was not very many protections for staff in terms of being able to access sick leave. So it sounds like in the UK, there's no requirement to be entitled to sick leave for these workers, and there is a statutory system which provides some sick leave, but that is capped at £90 a week, and you have to work a certain number of hours to be able to be entitled to that leave. And a study by the Union of Aged Care Workers found that 55% of the carers in care homes don't have access to any sick leave, so they either don't work enough or their organisation just doesn't provide it. And so that's a real incentive for workers to then present if they may be unwell, and lead it to be very difficult to control outbreaks. And it sounds like they're still working on when and how to accept hospital discharges to care homes. But again, that's not necessarily a new issue or something that's unique to the UK. And it made quite chilling reading, and I don't want to cast aspersions. It sounded like they were trying to manage a really difficult situation, as we all have, to the best of their ability as they go along. But certainly it's reassuring looking at some of these challenges that they're faced, to see that for a lot of them, we are in a very good position here in New South Wales. We have very good access to testing, particularly for workers. So any aged care facility worker should be able to access a test near their home without much trouble, because we've got very relaxed testing criteria, and we're really putting out that message to encourage people to get testing. So that's one great thing. And also the ability to test residents in the aged care facility. It sounds like, I know in the Central Coast, we're developing a Go team that can go out and potentially swab people. And that's, again, a real focus. So I think some of the challenges they've faced, hopefully we won't have to face, and we've been able to learn from their difficult experience to be able to address some of these things. Just to follow on from that, I'm not sure if any of you else saw this article in the Sydney Morning Herald today, but I just thought it was a wonderful example of one nursing home in France going above and beyond. So in this nursing home, they actually, very early on in March, when COVID was emerging and they were going to go into lockdown, about half the staff volunteered to stay in the aged care facility with the residents. And so they brought in their sleeping bags and their pillows, and they've actually been living in the aged care facility for the last 47 days while they're in lockdown, to prevent themselves from going home and then catching COVID and reintroducing it into the facility. So I just thought that was quite a lovely gesture and representative of how hard some of these workers in aged care facilities work to look after their patients. So just to sum up the key learnings so far from the international experience with aged care facilities, residential aged care facilities and their residents are really highly vulnerable to COVID-19. They're sitting ducks not only for COVID-19, but for an outbreak, and to have high death rates. And so we, collectively at all systems levels need to be really aware of that and doing everything we can to try and manage that risk. So I guess for people in the community and for clinicians, the key most useful thing would be to have a high index of suspicion and a low threshold for testing for COVID-19 in any aged care facility resident and any worker. Because if we can detect it early, then we can put in all the measures we can to try and stop the spread. And finally, all aged care facilities should have a preparedness plan that accounts for how they'll manage PPE, how they'll manage infection control, how they'll seek testing if they need it, and also how they manage their staff, and in particular, how they will manage staff that need to go into quarantine and staff that become unwell, because it's really important that they can staff their facility, even if some of their staff end up being contacts and have to be quarantined for 14 days. And also the need to make sure they support their staff not to present to work while unwell. So that's the end of my slides. And I'm happy to take any questions at the end, perhaps.
Thanks, Catherine, and apologies about the technology earlier, but you did very well to recover from that, so thank you so much. We'll carry on with a couple more presentations, but note that we have lots and lots of questions and we're looking forward to hearing some of your advice on this. So I'm just going to give a very brief update on what the PHN response to COVID else is focused on at the moment. So a quick update, Catherine mentioned the community respiratory clinics. We've got 2 operating now, one at Raymond Terrace, one at Erina, which is seeing lots of people at the EV Church on Terrigal Drive, and there will be one opening in Tamworth on Thursday, which will be also available for respiratory consults and testing. So they're actually doing their training today, so we should have that finally happening soon. We're also working through applications for telehealth grants, so we've had a number of general practices apply for some assistance for telehealth. There's also a lot of questions about telehealth, so we'll try to get to some of those later. Those are still available if people are interested. We're also, we recognise that there's a lot of impact on local allied health practices at the moment, including challenges around access to masks and other protective equipment. I am able to tell you that we've received a very large supply of surgical masks from 2 charitable organisations, from the NIB Foundation and from the Society for Health Administration Programs in Education. And there is a link on the PHN website if you are interested in accessing some surgical masks, so we're able to assist with that. So they're probably the key things at the moment for us. And I will now hand over first to Jackie and then to Mel to talk about a bit more about the specific support programs that the local health districts are providing. So over to you, Jack.
Thanks, Catherine, and thanks for having me here tonight. I'd like to thank Catherine on the Central Coast for a beautiful segue into my next session. And it's about the preparation for COVID-19 in aged care facilities and the health pathway that we're building that sits beside or in conjunction with the assessment and management of COVID-19 in aged care facilities. I don't think I need to reiterate anything about learnings from overseas. Catherine did that beautifully. I just hate to be the doom and gloom person and say it's not a matter of if we get COVID-19 into an aged care facility locally, it's probably likely to be just when. So just to touch on some learnings that have come out of the Dorothy Henderson Newmarch and Newmarch lessons. There were residents that were already infected and incubating before infection prevention and control measures had begun. And there were widespread breaches of infection control post-outbreak. They had difficulty maintaining adequate staffing levels, especially at the start of the outbreak. Communication strategies weren't planned, and there were distressed families and residents due to no visitation, and that has long-term consequences for mental health and bereavement. Other learnings that have come out was that their advanced care plans and directives were largely not up to date, and they needed just-in-time training and retraining with infection prevention and control and PPE donning and doffing, as well as more than annual updates. Clear outbreak planning and implementation processes were not always followed. Engagement and coordinations of GPs or specialist physicians to plan and manage the outbreak needed bulking out. There were no media plans necessarily that came from the aged care facilities, and out of Newmarch there was, asymptomatic but an infected staff member. So I'm just going to talk about very briefly about the difference between standard precautions, and contact and droplet precautions. For standard precautions, which is what we're recommending in people returning home from hospital that are non-COVID, is just 14 days isolation and standard precautions. Carolyn mentioned that earlier. I think there's been quite a bit of confusion around that, and I think we just need to be sensible around our PPE management. In this preparedness page that's in draft form at the moment and hasn't gone live, this is how we're going to walk you through being prepared for an outbreak, and we've broken it up into outbreak prevention, and all those hyperlinks take you to education or documents that will support you in how to manage your or to start planning for your infection control. The PHN have commissioned some education resources and other resources, and amongst that is a visitor checklist, and that's available, and you can also add a column to that checklist where you can look for, you can record evidence of immunisation for influenza. Infection control continuing. Cleaning requirements, you all know what those are, but we are recommending increased auditing around that. The main thing that I want to discuss with outbreak prevention and be prepared for is preparing the family that you may need to plan early for possible bed movements if there is an outbreak in the facility. And having worked in and with aged care facilities, I know that that can be tricky. So I think the sooner you start those conversations with families, the better for everybody. We'll talk about clinical supplies. We've developed a lot of documents. One that was mentioned earlier that has been approved by our governance today was planning for supply of oxygen. As we know, the main treatment is supplemental oxygen for supporting the resident while they're unwell, and this is going, in an outbreak, going to require increased amounts of availability of oxygen. There's preparing for oxygen therapy in an outbreak advice for residential aged care facilities in our documents, and I really recommend that you look at that and prepare for that event. Again, if you're going to manage them in situ, you need to work out how you're going to manage things like infusion pumps for end of life, IV fluids if it's appropriate, and cannulas, and end of life management. So all of these documents are within this preparedness page, and it's been very widely collaborated to bring the best information to you. With the outbreak preparation, as I said earlier, the PHN have commissioned education resources. I'll go through those shortly. But to prepare clinically, you need to review your outbreak management plan and coordinate with your GPs. You definitely need to update your advanced care plans, any chronic disease plans, any PRN medication, have it up front. Talk about BiPAP and CPAP if it's in the facility. And again, review the use of nebulizers, and talk to your GPs, or GPs if you're listening, think about de-prescribing any unnecessary or burdensome drugs, and do a medication reconciliation. Communication, as I touched on earlier, family and resident, have a communication plan that has a single point of contact with the family. I know how it can get out of control. Make sure you identify the right person to talk to and make it clear that it's their responsibility to talk to the rest of the family. Include, of course, room for preparation for urgent bed moves. Think about who's going to do that. Logistically, that's a a big job, a very big job. So you need to plan for that in advance. Distribute the resident and family COVID-19 information sheet. Think about a strategy, how you're going to inform families on a daily basis if you haven't already, many of you have. SMSs, emails, however you like to do it. And also incorporate for the increased use of telehealth or social media or Zoom meetings or whatever it is to keep families in contact. It can be a big drain on your Wi-Fi. So you need to plan for that. We've talked about keeping the staff safe, and there's some information in this health pathway about daily safety huddles with staff. And in that you can clearly communicate what the expectations are for all staff, clinical and non-clinical, in that, and it also looks after staff wellbeing. And you need to think about a strategy to keep GPs informed about your current status. It's really important to keep these partnerships very healthy during this time. And of course, outbreak preparation, education, and practice, particularly donning and doffing. Our recommendation is if you're doing this, if you have an outbreak and you're donning and doffing, have a buddy with you to make sure that you go through the processes. We all know that contamination mainly occurs in doffing, and it's a practice that's used in hospitals, and I strongly recommend it. And don't forget your GPs in all of that, and anybody else that might need it. This is just where you can find the PHN education resources. I'll leave you to look at that later because I'm on a deadline. And this is an important one. The logistics of working out your workforce if you have an outbreak. You need to identify very early who's going to be your outbreak management team and assign roles and responsibilities so it's all very clear. And you need to discuss this with your visiting GPs so that they can work out together who they're going to defer to, if necessary, to be the clinical lead in an outbreak. There are GPs out there that possibly should not go be in a COVID positive environment because of their own, they might be older, they might have autoimmune disease, they've got reasons why they may not be, and so that's why the GPs as a group probably need to work this out with staff and management of the aged care facilities. We want you to plan your surge workforce, include staffing agencies, and review your leave, which you've probably already done. As Carolyn said, we've pulled together a list of locally used agency staff, line them up, casuals, whatever you need to do. And again, cohorting residents and moving people around requires a lot of planning and a lot of logistics. And looking into a residence room, if you've all been into a residence room in an aged care facility, you've got doilies, photos, paintings, everything that will have to be moved too. And sometimes it might be advisable to ask for some of those extra things in the event of an outbreak to be taken away by family. I just want to very briefly mention that the PHN have been developing a capacity tracker that they're working with local and international partners on a system to monitor the capacity of aged care facilities and general practice in real time. It's app-based, and it will help us identify and assist you in the response to capacity issues in the event of a COVID-19 pandemic, an outbreak in your facility. To register is very simple. It's on the screen, and if you hit the help button, it takes you to videos that talks you through the whole process. So that's it from me, and it was very quick but I'm happy to come back or answer any questions. And now I'm going to hand over to Mel. Thank you.
Thank you, everyone. I'm Mel Pickering. I'm the Acting Director of Nursing for Community Chronic and Complex Care. And today I'm just going to go and provide a bit of a brief overview of some of the support that we have available through our district to support the residential aged care facilities on the Central Coast. So the Central Coast Local Health District's services that we have available to support the care needs of residents within residential aged care facilities include our aged care response team, which also incorporates 2 nurse practitioners, our dementia and behavioural support services, our palliative aged care service, our acute post-acute care team, our community allied health team, our older persons mental health, our behavioural assessment intervention service, and we also get some support from our specialist medical clinicians from our geriatrics as well as our palliative care team. If we can just move on to the slides and the next slide. In regards to being able to refer and access any of these services, the district has been working to try and streamline access and ensure that we can maximise the benefits to the residents, carers and the facilities, and by going through a central intake, which is our community health access and intake. You'll see the number on the screen there, which is our 1300 725 565. We've recently just extended the hours of our intake service, just commencing on the 14th of April, where we now have it in operation with a clinician at the end of the phone from 8 a.m. until 8:30 p.m, 7 days a week. CHI is our referral processing centre, and it was back on the previous slide. We still have our CHI is our referral processing centre that provides a central point and coordinated access to all of our services. So we are able to answer and provide any support, but also direct the call or the referral to the appropriate service to meet the needs of the residential aged care facility. Moving on to the next slide, I just wanted to touch on our aged care response team. So our aged care response team is a nursing team that consists of registered nurses and 2 nurse practitioners. They're available 7 days a week from 8 a.m. till 7:30 p.m. And as part of the healthcare team, the care elements that they provide are a comprehensive assessment, clinical nursing consultation, provision of care and coordination, and the care that they can support you with is quite varied. It can include things from complex and or deteriorating wounds to palliative care, end of life. They can also support care needs where there's an infection present, falls, or really just general support or advice as required. They can also, with our nurse practitioners in place and in consultation with the general practitioner and or a medical officer, they can initiate diagnostic interventions, and they can also support the facilities with generating a care plan that meets the needs of the resident in consultation with the medical officer and the care team around that resident. The other thing that the aged care response team are able to do is support education and training within the facility. So one of the things that we are going to be looking at doing more of is identifying with the facilities where there may be some gaps in education and training, and looking at how we might be able to support facilities in improving those gaps, whether it's through us doing a bit of a train the trainer and providing that education within the facilities, or us going in and providing that expert education in place. The other thing that we're going to be doing with the aged care response team, and we've just started and we're in very early stages, is rolling out telehealth. Part of that will be looking at the telehealth capability within residential aged care facilities to support that, but that will allow us to, particularly with our nurse practitioners, to provide a remote assessment where it's difficult to cover the whole Central Coast with only having 2 of our nurse practitioners in place, but also being able to work with the facilities on generating care plans remotely that meet the needs of the residents where it's safe to do so, and ensuring that we're incorporating the GP as part of that conversation. The other thing we're doing with the aged care response team is working to enhance that team and hopefully being able to have additional nurses that will enable each nurse within that team to have allocated between 10 and 12 facilities each across the Central Coast. And that will allow them to provide support and facilitate, I guess, proactive communication and a link to the other specialist teams that might be able to support the care needs of residents in their home. If I just move on to the next slide, I just wanted to give a very brief update on what we've been doing in the COVID-19 space to support our residential aged care facilities. As you're aware, and as it's already been touched on, New South Wales Health has recommended that anyone with respiratory symptoms or unexplained fever should be tested for COVID-19. And it's especially important for anyone who lives or works in those high-risk settings, which was touched on before, which one of those is the aged care facilities. Now, what we've been able to do within Central Coast Local Health District is train some nursing staff to be able to respond to COVID-19 screening and swabbing education, training and support requests from facilities. So we acknowledge that there are some facilities on the coast that have already got staff trained to do this swabbing, but we are there for those facilities that either require some renewing in their education or they don't have any staff trained yet. So please, if you are a facility that currently don't have anyone that is trained to do this swabbing and you have a requirement to have any of your residents swabbed, you can contact our Community Health Access and Intake line and we can certainly arrange some education to support you in that space. And that was really all of my update from Central Coast. Thank you.
Okay. Thank you very much, Mel. I think we're back here, Todd. Indeed. Terrific. Well, look, thank you very much to everyone who's contributed. There's so much content here, and I know, Charles, you've got content that you're saving for another night now, so we can launch into some questions. Thank you very much for that. And there are lots here, so we'll share them around, and if Mel and Catherine can stay accessible too, we'll work through these. Thanks to everyone who's upvoted. So we've got half an hour or so. Why don't we start with an impossible question, Carolyn? So Milton's asked, it's just invidious question of the wandering aggressive dementia patient who is infected with COVID. What advice do we have for management in a dementia unit?
If you actually go to the Health Pathways page that we've done, there's some links to the Dementia Services Australia recommendations in regard to dementia patients and COVID. And they're also available with their rapid response team to come and assist with aggressive patients. I think my experience and recommendation in regard to DSA is to really know the keywords in order to activate them, which is around staff and patient resident safety. But I'm happy to talk about that some more. But ultimately, if you actually read through the DSA document, it says if required, the resident can be sedated in order to get control of the situation, because I think when an outbreak occurs and it's a public health order, in some ways, sometimes the safety of the community and the population actually overrides the individual's right of care.
It is an impossibly bad situation, and so there is the option, as you say, of the public health order. It's not an attractive option, but it's the lesser of two evils in that setting, potentially.
But it's an extremely difficult situation that we will have to deal with, and I don't know if you've got anything to say in regard to that, Charles, but I think
my issue would be is how you're going to swab the patient who's physically fit with dementia, who is difficult to get a blood test from, it's difficult to get a urine test from, and now we're going to try and do a nasopharyngeal. So as to whether we sedate the patient or whether we can restrain the patient, I don't know. It's going to be a very difficult one. I don't know what Newmarch had, whether they
it'd be interesting to learn from them
how
when
they
we
learned
hear.
from that one.
But I think everything is a risk assessment, isn't it? And the risk to the patient and their safety of the staff versus getting the test. And if there's an outbreak and the patient's got symptoms, do we need the test anyway, would be another kind of thing to say too. So I don't know that I know the answer, but it's somewhere in amongst all that.
Yeah, but there'll be a group helping work through that. Indeed. Do you want to choose we can alternate if you like. We'll work down the list.
Yeah, let's go through the list. What were the big contributions to the outbreak at Newmarch? I think Jackie covered some of those things. We still don't know a lot. There's most of the information, even I think that we're receiving at a LHD level, is still via the media. So I think we've got some information around Dorothy Henderson, but we've got less information around Newmarch.
No, and I think we're obviously looking for that down the track ourselves very much for learning. So we've learnt from Dorothy Henderson, but there's more to come.
Yeah.
Look, there's a question here that has a number of different iterations, but it's around testing patients before they return to a nursing home. So thanks, Anita, asking, and the colleagues have voted up. So these are asymptomatic residents who don't have COVID but have left the facility for any reason, and testing, actually swabbing and testing, not just screening for questions, but swabbing and testing is being requested before patients return, with GPs being asked to sign. I know this is a source of consternation and some tension. So I've seen the New South Wales Health Policy shared, and it's online on their website, is to follow the national guidelines, the SONG, which would have swabbing for people with confirmed COVID infection before they return, of course, coming back to a high-risk setting, but not in other contexts unless symptoms warranted it. But Carolyn, you've been in the middle of this too, in terms of...
Yeah, so it's difficult, but I think the logic is that even if someone was swabbed negative, that they still could have COVID, and that's why they still need standard precaution and isolation. And I think, again, maybe going back to Milton's question, the challenge is that the patients who have cognitive impairment and a walking with purpose, that they are very difficult to contain, and therefore maybe a negative swab allows them to be more mobile in the facility, but I actually don't think it does, and that really we need to be vigilant with patients even if they had a negative swab. So in some ways the negative swab doesn't change the management.
No, not for the next day, no, that's right. It's time limited value. So look, you've got, if you're finding this troublesome and you're under pressure to sign for swabs for people who don't have COVID, they're just asymptomatic and returning, that New South Wales Health position is there. There on the website.
I think there was another question further down about the aged care facilities are refusing to have the patients back. I think my advice, I suppose, in regard to that is always that senior people need to talk to senior people, and often when, as a senior doctor or a senior nurse, you talk, or a GP, you talk to the facility managers or even the organisational managers, then you can often negotiate a different answer. And really, I suppose it's always important to remember that the aged care facility staff have actually got the residents' best interests at heart, but maybe don't necessarily understand the nuances of the evidence, and that it's our jobs to get to work together and negotiate the right outcome.
Now, I was going to try throwing a question to you, Catherine, but the screen's gone blank. No sound there at the minute, so we'll field that one ourselves. It's a variation. There's a number of people who've asked a question similar to this. So is it possible to contain a COVID outbreak in an aged care facility? Does it make sense to even try? Should people with COVID infection in aged care, in the aged care setting, just be moved out of the facility at the first opportunity? And so I guess I'd just come back, we'll share this response, but I'll come back to some of that brief evidence I presented even at this early stage in the New South Wales experience. So there's been a couple of big outbreaks, and they're sobering, and that's why we're paying this so much attention. But there's been a whole series where there's just been one or two staff people with no transmission, or one or two residents where it hasn't got away and become an outbreak. One of you particularly asked whether that was possible for COVID to be present and for it not to develop into a full-blown outbreak, and it certainly is the case. So we are very much operating on the principle that managing a COVID outbreak in an aged care facility is something that we will attack vigorously right from the start, expect to be successful in doing that, but recognise that it might be enormously challenging on the way. Do you want to add to that?
I think some of the things that Jackie and I have been talking about, I suppose in hospitals, we've been talking about green, orange and red zones in hospitals. So the red zones for the patients who are COVID positive, the green zones are for the patients who are COVID or asymptomatic, and then the orange zones are the sections in hospital where we're managing suspected cases.
Yep.
And perhaps we haven't thought this through yet, but I'm thinking that cohorting patients and cohorting residents into areas within aged care facilities is probably going to be one of the ways that we can manage, because if you think about even the cruise ships, if an aged care assistant is moving from a non-COVID patient to a COVID patient to deliver care, and then the next patient's non-COVID, it's actually quite a risk in terms of cross-contamination. So cohorting the residents into one area is probably, when there's a big outbreak, is probably the way to manage it, I think.
I think there'll be a strong case for both cohorting the residents and clearly, as you're applying, cohorting the staff too, so there wouldn't be movement between an infected group or potentially infected group and non-infected group.
Yeah. Any thoughts on that, Charles?
Yeah, I was talking to one of the facility managers, and they said that if there was one patient infected, they would leave them in their room. If there were two, then they would probably leave them in their rooms. Once they got to 3 and 4, they would probably isolate them into a separate building. My thoughts, and this is the ships, I think, are incubation places where people get incubated, and keeping people on ships for a long time, it's just going to spread further and further. Particularly with staff that probably are not used to PPE and so on. And my thought is that, if you've got a facility that is one building that hasn't got separate areas, you might have to consider transporting the good patients out or the infected patients out to try and reduce those numbers. And I think with Newmarch, it's just spread round and round, and trying to really isolate people is really important.
Yeah. And one of the principles in that CDNA outbreak preparation document is around the outbreak identifying the outbreak management team, and I would think that governance team would have a really important role in talking through all those issues around how can we do this, but also I think having a really clear communication strategies with the families around what has to be done.
Is it in preparation for an outbreak where you might be moving people around the facility and where single rooms, like I appreciate many facilities have a fair number of single rooms, but they will be incredibly important resources in the context of an outbreak, of course, for keeping people separated. So there may well be need to move people around.
Yeah, and we thought as part of the preparation work that needs to happen is that there needs to be communication out to the residents' families now to say, look, if we hope we don't have an outbreak, but in the event that dreadful thing happens, it's likely that the residents are going to need to move around the facility in order to manage the outbreak.
And we've kind of touched on this, I guess, but one of you has asked about residents returning to the facility. Do they need to go into isolation? Now, clearly, somebody who's been out of the facility who has COVID will have 2 negative swabs before they come back. That's an absolute given. We've talked about there not being a requirement at a New South Wales Health level to swab other people who are asymptomatic coming back. But Carolyn, you touched on this as a recommendation for how facilities in Hudson, New England should manage residents returning from, say, a visit to hospital for a fracture repair or something. Do you want to comment on that further?
Yes, I suppose we've written some documents that need to be approved, but our current thought is that the residents need to be screened, which is, have they got respiratory symptoms or fever?
Can we just dwell on that point, because it's something that trips people up, and thank you for one of you down the list has pointed out the potential misunderstanding in terms of language. So screening in this context very often means asking the right questions, the screening questions. Not taking the swab, and so the potential for confusion there. So you're talking about questions at this stage? Yep.
So screening the resident, if they're not a suspected COVID case, that they go back to the aged care facility, that they're in self-isolation, so they're in a single room for 2 weeks. They can still have visitation from their families. They can and they can still receive care from the staff, but the standard precautions need to be used. Which
Yeah, so it's not gowns and so forth, but the real attention to standard precautions, as you say, which is essentially really good hand hygiene, which we ought to be doing with everybody all the time in any case.
Yeah, and
so this is a step up, because this is a new recommendation, isn't it, in the context of COVID? Yeah.
One of the questions we had, and I'm not sure if it was here, but it certainly come from one of our GPs, was around a community visit. So if a resident goes out to an outpatient appointment, like sees their GP, or goes and has an X-ray done because they've fallen over and have a sore wrist, should they go into isolation? We think based currently on the prevalence in the community that that's not required, but we think it would be a good idea for them to wear a mask when they're out, and again to be practicing hand hygiene, and then when they're coming back to the facility, as with all of the residents, being vigilant around symptoms and again those baseline observations. So I think they don't need self-isolation if they're going to a community visit, which is a different level of risk to a hospital visit.
That's right, it might be a community-based ultrasound or X-ray or something like that, indeed. There's a question from Anonymous. How infectious is a body after death? So it's an important question. And so I guess it boils down to what are the practical requirements after death. So there's obviously potential for transmission from surfaces if somebody had COVID. The requirement is not too onerous. It's for a body to be managed with double bagging. And then managed through the standard processes by funeral directors. So there is a requirement for double bagging, but it's no more onerous than that. And of course, handling somebody who's deceased ought to be accompanied by the appropriate kind of PPE for their context. If they had COVID, clearly there'd be PPE associated with
Charles
that.
had
Just like to add to that, Tony, the issue of death certificates, you don't actually have to view the body, assuming the patient has been looked after, within the last 3 months. You can issue a death certificate without seeing the patient. But in the case of a cremation certificate, it's got to be viewed by 2 people, 2 medical practitioners, and the one medical practitioner is usually the person that looks after the patient, and the other medical practitioner is just somebody who the crematorium bring in just to view that the body is actually there and identify the name and so on. So I don't think there's an issue with cremation in the sense of PPE, because you actually have to view the body, you don't have to examine it, touch it, and so on.
Can you do that via telehealth?
No, well, no, that was tried by some of the undertakers some years ago, and that was, no, it was a definite no. Yeah, it has to be viewed physically.
And with the concept that if you cremated the wrong person, that would be quite a terrible thing.
Yes, well, you just got to check that there's an actual patient there.
Yeah. Okay.
Yes.
Next question I have here, then I'll pass back to you, Caroline, this might be one for me. Is there a guesstimate of the prevalence of barely or non-symptomatic coronavirus in the Hunter to assess the odds of a case walking into a nursing home at present? It's a great question, isn't it? What's the chance of anybody walking around having COVID? And clearly it's tied to where we'll end up at some stage soon. What are appropriate levels of precautions for people coming and going from residential aged care facilities? So I'll get you to comment on that at the moment. Now, clearly the drive to test as extensively as we are is very much driven by this desire to identify exactly this question. How many people are there in the community who have COVID in whom it's not recognised, either with no symptoms or with very mild symptoms? And every week that we go past, you saw those epicurves from Catherine and in Central Coast and ours in Hunter, New England, and it's now been at least a couple of weeks without cases. That's enormously reassuring. We know there's potential for COVID to be asymptomatic and go under the radar, hence the need to continue testing widely with your help. And as the week goes by, we'll be more and more confident that that chance is low. Clearly, potentially, consequences are disastrous, and so strict screening criteria as people come and go from residential aged care are a key step still. Haven't directly answered your question, I'm afraid. It's clearly low, but we don't know how low until we do more testing for a couple more weeks at least. But in terms of what's appropriate as people come and go from facilities at the moment, Carolyn, do you want to talk to just the importance of that entry screening for people coming to facilities?
Yeah, so I think in hospitals now there's a single point of entrance, and that patient visitors, staff are all screened around symptoms. Hospitals now, they're all having their temperature measured. And then I think in aged care facility there's a requirement around influenza immunisation. So I think they're the requirements. But and then the Jackie, whose guidelines is it? The not cDNA, around visitation from, because obviously it's a pretty controversial area. Oh, that's is that cDNA?
Public health.
Yeah.
Oh, well, there's a public health order at a New South Wales level
New South Wales level
limits visits to
2 hours.
2 hours in the day from one visitor. So that's a public health order that still has standing. So it's not possible to have any more than that, but we appreciate some have been additionally cautious beyond that.
Here's a good one that's related to that for you.
For me?
Yeah.
Right, thank you.
What do we tell our patients who want to hug their grandkids and have them stay over?
I thought you might ask me then. Look, this is a real challenge, isn't it? And there's not a straightforward answer, but there might be soon. Is it Switzerland who's actually doing a study of this? There's a country in Europe who's actually set up a study to look at this risk exactly, because it plays out in every country, of course. The general principle, of course, is that we're encouraging people to practice social distancing and to maintain that 1.5 metres. So that's the straightforward response. But we will have more information on exactly this, because it's something that we really all want to do. So formally, I recommend the social distancing for all of us, and I look forward to sharing some more information down the track.
I think there's a question here from Joe Wood about Newmarch has an on-site infectious disease physician in the event of a large outbreak. What LHD supports will be offered?
Great.
I think that it's interesting to know, isn't it? I suspect with our first few outbreaks there'll be a massive response by New South Wales Health. But if we end up, like Catherine talked about, with 86% of aged care facilities, which is around 200 for Central Coast and Hunter New England, that I suspect there'll be less involvement further down the track. Is that a cynical answer?
Well, I mean, we'll need to work out.
Yeah, and I suppose we're the other part of it. If I'm being the diligent answer is, I suppose we're learning a lot about the outbreaks as they occur, and that once we're maybe more expert, we'll be able to offer. Or less support will be required from the aged care facilities.
Lots of us will build up skills, but I think it's the point you made earlier, there's just enormous support at the level of the state and at each of the health districts, with an expectation that there'll be both a lot of support and a lot of oversight of outbreaks in aged care settings as they occur in Hunter New England and the Central Coast. And
we're talking through that locally around how that'll work, and certainly Hospital in the Home has been doing a good job with patients living in the community. But I think one of the issues is actually around the patients, and maybe Charles can talk about this, that if you're a GP and you've looked after a resident for a very long time, it's actually quite confronting, I think, for some GPs, and maybe disrespectful for some GPs when an outbreak team comes in from either the Commonwealth or state government and takes over the medical management in an aged care facility. And maybe do you want to talk about that, Charles?
Yes, I mean, the impression I get from Newmarch is that they've brought the professor in of geriatrics, and they've got a doctor they brought from outside working there. I guess, you know, a lot of the residents that go into nursing homes, commonly the GP follows them through. And they know the family, they know the history and so on. And I think it's really important that the GP stays connected with all that. They don't necessarily have to go into the facility, but just communicate and maybe be one of the communicating people or the supporting people for the family And I think with Newmarch, the communication there probably wasn't as good as it should have been to begin with.
Yeah.
And maybe the GP can help with, the nuances of the different families and so on.
Yeah, and I think that, so we've been, as we're writing this district preparation plan, we've been really mindful of that. And, there'll be some GPs who can't go into the aged care facility, but I think the aged care facilities will all need to start planning and communicating now with the GPs around what they think might happen when there's an outbreak. But once there's an actual outbreak, there's really going to need to be some method of daily communication with families, with residents, with GPs around what's happening, because I think that's, to me, if you look at the media, the big issue for Newmarch is probably around the communication strategies and not having them in place before the outbreak.
And probably the media too.
The media loves a dramatic story, don't they? So we're not, which is why we can't really comment on Newmarch in lots of ways. I do have to say there's a fabulous, if you get the opportunity, there's an amazing ABC interview with the CEO of Newmarch that I'm happy to circulate the link to. But he just sounds like such a kind and thoughtful and engaged man that I thought I'd love my family to be in an aged care facility with someone like that in charge. So I think it must be, I think when you see Newmarch, you think, my goodness, I'm glad that's not me.
No. I think probably part of the preparation, a couple of things that I've observed in some of the facilities is that the nursing staff are very good at doing observations, but one of the observations they tend to forget about is the oxygen saturation, which I think is really important, particularly with this disease. And the other thing is, as you mentioned before, the advanced care planning, to have an up-to-date, and the facilities that I'm involved with, we've asked that they all update them, so that they're recent rather than 2 or 3 years old and so on. A couple of important parts of preparation, so we really know what we're dealing with, whether it's palliative care or not.
Did you have anything else on your list there, Charles?
We talked about the cremation, just the hospital transfer and the standard. You don't have to wear PPE if somebody comes back from the hospital and they're COVID negative, and just the standard precautions. I think that's really important, because I think sometimes people, the minute they come back from hospital, we've got to use full cover, and it's not appropriate. I
think another thing one of the GPs raised with me is just around the PPE training. So Jackie mentioned the Rebec videos that are actually really good. There's a whole lot of resources, but I think it would be actually good now for some of the aged care facilities to actually practice the donning and doffing now, and getting the staff to work through it, because I find, even working in the ED, I suppose it's an interesting philosophical perspective, really. We're actually asking staff to do what they've always supposed to have done, which is always wash your hands. If someone use respiratory precautions, if someone's coughing, if you're doing a high-risk procedure, you need more precautions. So we haven't actually asked them to do anything differently to what we should be doing. But it does impact on my role as an emergency physician. I find that I'm a very sensory person. Maybe that's me, but like I'm always looking and listening and smelling and kind of having a sense of the ED as the person in charge. And when I'm in PPE and I've got glasses on that are fogging up, I've got a hat on that covers my ears, I've got gloves on I can't feel, I actually find it really difficult to be a clinician. And I think that's the challenge of PPE. But yeah, as I said, donning and doffing properly is really hard. And the thing that we've really emphasised at Belmont is the importance of the buddy, so that ambulance, any of the ED clinicians, if anyone's taking off their PPE, that we go over to them and say, can I help you? Let me just watch you taking off your PPE, because our role is to keep everyone safe.
I think the experience in the nursing homes is the shortage of staff, and there are probably two staff members looking after a series of residents. And
get the residents to help.
Yes, but sometimes you're in the room and you need something, and the other person's at the other end of the facility. I've had experience recently in country hospitals and there's a shortage of staff there, and it's uncommon to have a buddy. And that's, I think, where the nursing homes really will have to look at increasing their staff appropriately for that.
Yeah, in an outbreak, absolutely,
Yes.
yeah.
I wonder if we might just try crossing Catherine and Mel. I hope you've been able to listen there. We'll just check the sound, and I guess I'm just throwing any of those questions to you for a comment on a Central Coast perspective. Catherine, do you want to try your sound? Yeah, I can see you on the screen at least now.
Yeah, can you hear me?
Yes, yeah, that's great. So just an invitation to talk to any of those questions. I appreciate we've brought a Hunter New England perspective today.
Sorry, I'm trying to think back. So I suppose more that one about, what are the chances of an asymptomatic person walking into a nursing home? Similarly to you guys, I think at the moment on the coast we can feel pretty confident that we probably haven't got very much. But I would also agree with the earlier comment that it's probably a matter of when, not if, we do get an outbreak. And we have got, we would at the LHD level be sort of in a position to offer a lot of help for probably the first 1 or 2 outbreaks we got. And we've been certainly at the public health unit level and within the LHD. And sorry, please add on, Mel, if you've got anything, been working that we would be able to do that, but also if the more outbreaks that might happen, the less able we would be able to offer that. So certainly all this preparation, talk of being well prepared for the facilities and the GPs to support them is essential.
Catherine, thanks very much. And Mel, I think we have a technical reason for not being able to cross to you just with the way the sound's set up there. I'm sorry about that. We can try. Would you like to throw anything into the mix at this stage, Mel?
Can you hear me?
Yep.
Yeah. Yeah, I was just going to agree with Catherine, and I guess just from a Central Coast perspective, one of the things that we have been providing and offering to some of our residential aged care facilities is that education in donning and doffing of PPE, just to, I guess, go on the back end of you talking about that needing a buddy and the recommendation to have a buddy there. That is something that we can support residential aged care facilities from an education and training aspect.
Fantastic. Thank you both. I think that worked nicely. I was wrong about the sound, Mel. Excellent. Look, we are very close to finish. I think we can sneak in 2 questions. I've got, can GPs refer to the hospital in the home, or do you need to send via ED? So please have a look at the health pathway. Sets out the mechanism. The answer is yes. GPs can refer directly to the COVID care in the home. They love that attention, and they're...
And they could refer anyone to hospital in the home. Hospital in the home, one of the referral pathways is definitely general practice. One of the really good programs that we could talk about for another hour is Healthy at Home, which is a really good program for frail older patients living at home. It's fabulous. It's got geriatricians, it's got allied health, and it's really good. But yes, GPs can definitely refer to hospital in the home.
Yep, so great question, and we should...
And then the last one was around McDonald Jones Stadium, my God. Anyway, we'll do a great job, but there will be a phone number. It just hasn't been released yet because the phones actually won't be answered until, the phones won't be answered until Thursday, and the phone number will be on Health Pathways starting tomorrow.
On Health Pathways, and there'll be a lot of media too. I think you'll be able to pick that up pretty easily. So,
yeah.
And I think that's a good spot to finish.
I think that's well done, and we're right on time, and I know how important that is to everybody. So I'm just going to a couple of questions just to follow up. So the health pathways are available for all clinicians to access, and the links are on the PHN website, and there's also answers in the Slido questions about that. There are a number of other questions there that we need to follow up, and we will follow those up and make sure that information is available. There was one around secure messaging and some technical things that I don't understand either, but we'll make sure that that is made available to everyone. So I'd just like to thank the panellists. Every time we have one of these, I learn obviously so much, but I'm also in awe of the collaboration that we're seeing across the region and within the organisation. So that's been fabulous. Thank you very much. And just want to thank you all for for your contributions to providing assistance to each other and to be providing the level of care that we're experiencing currently right across the region in these difficult times, and thanking everyone for their diligence in preparing for the potential outbreaks. Mel is giving me a sign that says, please go to the polls on Slido. We really want to hear your feedback, and particularly about what else you would like the next topic to be on, because so the next one will be probably in a couple of weeks, I imagine, and we'll have more of an update on where we're up to in terms of COVID-19, but we would like to have a specific focus. So,
and we're happy to come back. I think that as we've kind of talked about, the outbreak management is a work in progress, and we're working on that health pathway. So we'd be keen to come back in a few weeks and maybe present a more lucid response to the answers.
Excellent. And yeah, so with that, I'll say thank you to our panellists and to our panellists on the screen, and thanks for hanging in there with the technology, and yeah, thanks everyone. Good night.
Good night.
Good night.
Good night. Well done.